Welcome back, everyone. We're going to continue the OBGYN series and discuss some of the considerations for the early pregnant patient. Firstly, let's discuss substance abuse. Illicit drugs can pass through the placental barrier and enter fetal circulation. So, use of recreational drugs can certainly create complications for the pregnant patient and the fetus. The fetus can develop birth defects or become addicted, and the fetus may have withdrawal signs post-birth. And we'll discuss the delivery considerations of the addicted fetus in a later lecture. Treatment should concentrate while the patient is pregnant on cardiorespiratory support, and treatment of overdose is similar for the non-gravid patient as the gravid patient. Cardiac conditions determine the nature and treatment of any underlying cardiac condition. As we discussed previously, cardiac volume and cardiac changes occur significantly during pregnancy, so there may be implications with cardiac medications, patients who are diagnosed with dysrhythmias or heart murmurs, any history of rheumatic fever, and then we'll discuss some congenital heart defects for the fetus later, but maternal considerations, if the patient was born with congenital heart defects, should be part of your history and assessment as well. And then note any episodes of dizziness or lightheadedness that are occurring during pregnancy. Peripartum cardiomyopathy is an uncommon form of heart failure that happens during the last few months of pregnancy or up to 5 months after giving birth, and can easily be confused with eclampsia. Hypertension disorders, you have chronic hypertension and gestational hypertension. Chronic hypertension is when the blood pressure is greater than 140/90 and the patient carries an increased risk for stroke or other cardiovascular problems. Gestational hypertension develops after the 20th weeks of pregnancy and tends to resolve spontaneously post-delivery. Preeclampsia. Risk factors for preeclampsia include pregnancy before the age of 20, women with advanced maternal age, history of multiple pregnancies, history of hypertension, renal disease, or diabetes, and it can manifest after the 20th week with a triad of symptoms that include edema, gradual onset of hypertension, and proteinuria, or protein in the urine. This may require emergency hypertensive treatment, and other conditions can accompany preeclampsia, including liver or renal failure, cerebral hemorrhage, abruptio placentae, and HELLP syndrome. Seizures in the pregnant patient pose complications, particularly for the prehospital provider, as treatment's difficult pharmacologically. The drugs that we use to typically treat seizures cross the blood placenta barrier and can create some potential problems. Benzodiazepines are generally categorized as class D, which means they may pose risk to the fetus. So we opt for the utilization of magnesium sulfate as our first-line seizure medication treatment in the gravid patient. Potential complications for seizures during the pregnancy is abruptio placenta, hemorrhage, and disseminated intravascular coagulation, which you'll remember from our discussion in hematologic lectures. Gestational diabetes mellitus is the inability to process carbohydrates during pregnancy. Patient may be asymptomatic or exhibit the same signs as patients with diabetes mellitus. Treatment generally consists of diet control and oral hypoglycemic medications. Diabetes may be affected by pregnancy, so make sure that you evaluate blood glucose levels accordingly for the diabetic patient that is pregnant. They can manifest as hyperglycemic or hypoglycemic episodes, and insulin-dependent diabetics may need to adjust their dosage of medication during pregnancy, which may lead to more frequent encounters with EMS during this period of time. Patients with a history of diabetes should have blood glucose levels tested. Shortness of breath or general dyspnea is one of the most common complaints for the gravid patient. This is often caused by hormonal changes, but as you can see in the image here, it's physical changes that occur as the diaphragm is shifted upward, also can create complications and additional shortness of breath. Underlying respiratory disorders can create some additional complications, including premature labor, preeclampsia, respiratory failure, vaginal hemorrhage, and eclampsia or seizures during pregnancy. Fetal asthma conditions can also create complications such as low birth rate, premature birth, growth retardation, and fetal death. Hyperemesis gravidarium, this is persistent nausea and vomiting that ultimately can lead to dehydration and malnutrition during pregnancy. The exact cause is unknown, but the symptoms are severe and persistent vomiting, projectile vomiting, severe nausea, and may be accompanied with pallor or jaundice. For these patients, we need to ensure that we are checking their blood glucose levels to ensure adequate glucose is present. We can start IV lines for advanced providers to administer normal saline and consider the administration of diphenhydramine if your protocols allow. We can also administer ondansetron or Zofran, IV or PO, if the protocols allow and your certification level is appropriate. Evaluating things like orthostatic vital signs and obtaining an EKG can help us further assess the patient's level of dehydration. During pregnancy, a woman's kidneys increase in length and the ureters get longer. The urethra dilates. These changes can lead to urinary stasis as well as urinary tract infection. The uterus puts significant pressure on the bladder when this causes urinary frequency. Rh sensitization is when the mother is Rh negative and the father is Rh positive. These are the Rh factors on the red blood cells, and this can create complications if the fetal blood enters the woman's circulation. This can produce a maternal antibody to the factor. This creates complications in which the subsequent pregnancies, the antibodies will attack fetal red blood cells. So the first pregnancy, this is not a significant complication if mom is Rh negative and dad is Rh positive. However, the antibodies that are developed during the first pregnancy will cause significant complications in subsequent pregnancies, and it will require that the maternal patient take medications that prevent those antibodies from attacking the fetus as a foreign invader. Urinary tract infections, if Streptococcus is passed to the newborn, it can cause problems with the fetus, including respiratory problems, pneumonia, septic shock, and meningitis. Other infections worth consideration include human immunodeficiency virus, or HIV. Pregnant women can infect the infant during the birthing process. They can help take medication to control the infection and try and mitigate the spread during childbirth. Cholestasis is a infectious process where the bile cannot flow normally as it builds up into the liver and then spills into the bloodstream. Symptoms include profuse, painful itching, right upper quadrant pain, and color changes in waste elimination. It's also hallmarked by this petechial type rash that you can see, and it's often in the upper quadrants of the abdomen. Additional risks or high-risk patients include patients that are carrying multiple fetuses, a familial history of cholestasis, and previous liver damage. While it's relatively benign and transitory, the fetus can be seriously impacted.